We're going to briefly talk about some pediatric emergency. It starts on page 287, chapter 43 of your ATI book. So if you think a child is choking, so if they're an infant, you're going to use a combination of back blows and chest thrusts, which is the picture in the bottom right-hand corner here. So if you've taken your CPR, you're familiar with this technique. It's different than with children and adolescents, which you use the typical abdominal thrust or what we refer to as the Heimlich maneuver. It's important to know not to perform a blind finger sweep in the mouth to get something out. And then the recovery position is for after, once they resume breathing, to help prevent aspiration. The important thing is to teach prevention of choking, so the age-appropriate toys and age-appropriate foods for the child. Drowning and near drowning. So near drowning we'll refer to as submersion injuries. This can occur in any water that is 1 inch or more deep, so mud puddles, toilets, sinks. A lot of parents won't think of that as possibility of drowning or submersion injuries. If it happens, you're going to want to get the type and the temperature of the fluid, location and time of the submersion. Assess the child's respiratory status, body temperature, assess for any bruising, any spinal cord injuries, and any other physical injuries that may be present. Injuries with submersion that can occur 24 hours or more after the injury would be cerebral edema, so watch for your signs and symptoms of increased intracranial pressure and, of course, respiratory distress. Teach prevention, so prevention is key, so wear a life jacket while boating, make sure there's a fence with a locked gate around pools, watch constant supervision around lakes and ponds. And then teach about the 1 inch deep, so bathtubs, sinks, and stuff that parents normally don't think of as causing drowning or submersion injuries, being important to teach. So if a child has a submersion injury, you're going to want to administer O2. Mechanical ventilation may be necessary. Assess vital signs, administer medications and IV fluids as ordered. Provide chest physiotherapy. So we talked about CPT in the respiratory play posit, and then we also talked about CPT or chest physiotherapy with our cystic fibrosis patients. So with our cystic fibrosis patients, they had the mechanical vest that vibrated them and provided that physiotherapy. Depending upon the extent of the injury, you're probably doing more of the manual chest physiotherapy with your submersion injuries. Use a calm approach with the child and monitor for complications of cerebral edema and respiratory distress. Poisoning. Before we move to poisoning, on page 288, your ATI book talks about SIDS prevention, so sudden infant death syndrome prevention. So we've talked about this multiple times in this class. I'm just going to point you to that page number so you can read over it and re-familiarize yourself with those techniques. So acetaminophen poisoning. So your signs and symptoms immediately after are going to be nausea, vomiting, sweating, and pallor. Your late signs are going to be more of the hepatic stage. So in between 2 to 4 hours after ingestion and your later, so days after, you're actually going to see some improvement about 24 to 36 hours after ingestion. The final stage of acetaminophen poisoning can be death or gradual recovery. Again, think of liver hepatic involvement. So if you know what your liver does, you can kind of know what acetaminophen poisoning can cause. Your treatment is going to be N-acetylcysteine, which you know that I'm really bad at pronouncing these names. It treats acetaminophen poisoning by binding the poisonous forms of acetaminophen that are formed in the liver. So your body can rid itself of the poisonous substance. Aspirin poisoning, again, this is on page 289. So acute, it's going to be nausea, vomiting, disorientation, diaphoresis, tachypnea, oliguria, lightheadedness, and seizures. Chronic poisoning is going to be more subtle signs versus what we just talked about. Maybe some bleeding tendencies, dehydration, and seizures are more severe in the chronic poisoning than in the acute. They're going to give sodium bicarb, oxygen, mechanical ventilation may be necessary, vitamin K to help with clotting so they can actually decrease their bleeding chances. And if it's severe and their kidneys are affected, hemodialysis may be needed. Activated charcoal is actually given and gastric lavage is performed. So common charcoal is made from peat, coal, wood, coconut shell, or petroleum. And activated charcoal is similar to common charcoal, but it is made especially for the use of as medicine. So to make activated charcoal, manufacturers heat common charcoal in the presence of a gas that causes the charcoal to develop lots of internal spaces or pores. These pores help activated charcoal trap the chemicals of the aspirin. This prevents the absorption of the harmful chemical of the aspirin. So it's important to know that not to take PO medicines if they're getting the activated charcoal, because the body won't absorb those common or needed medicines as well, as long as they're getting the activated charcoal. Supplemental iron. So a lot of people don't think of iron as being poisonous, but think of a lot of them will come in those chewy gummies that taste really good. So kids might think that they're candy or might eat the whole bottle before a caregiver realizes it. So initially they might have vomiting, bloody emesis, diarrhea, gastric pain, and bloody stools. But 2 to 12 hours after they ingest, they're actually going to improve their symptoms. And then the systemic toxicity period is like 24 hours after ingestion, and it's metabolic acidosis, hyperglycemia, bleeding, fever, shock, and possible death. So you're looking at about 20, maybe a little bit sooner than that, but up to 24 hours after ingestion. And then up to 96 hours after ingestion can be the hepatic injury period, where they have seizures or coma if the death didn't occur in the period within the 24-hour time frame. They're going to induce vomiting or do the gastric lavage, and chelation therapy is should be given IM or by slow sub-Q or IV infusion. Pediatric patients receiving the deferoxamine should be monitored for body weight and growth every 3 months, because it can affect that. Hydrocarbons or corrosives, so such as gas, kerosene, lighter fluid, paint thinner, or turpentine, cleaners, batteries, bleach. Think airway, because they're going to, if it's poisonous, they probably swallowed it if they're poisoned from it, which it can be very corrosive. So think airway, swelling of the airway. Do not induce vomiting, because that coming back up through the esophagus can actually cause airway problems. Think chemical pneumonia possibilities, and no attempt to neutralize the corrosive. It's possibly one of the greatest risks of gasoline exposure is the harm it can do to your lungs when you inhale it, so through the fumes. Direct inhalation can cause carbon monoxide poisoning. So think of carbon monoxide poisoning. We usually think of people running a vehicle in an enclosed area, so that's inhaling those fumes. Long-term exposure in the open, so if you're not in an enclosed area, can also cause damage to your lungs. Milk can actually increase absorption of some poisons, so avoid giving milk with anybody that you think has ingested a poisonous substance. Lead is a big one for our pediatric population. So it starts on page 290, so signs and symptoms of lead poisoning. So low dose lead exposure, kids can become easily distracted. They can be impulsive and hyperactive. And if you list those three things, easily distracted, impulsive, and hyperactivity, we always want to think about ADHD, right? Which we'll talk about a little bit later. But it can also be telling us that they have some low dose lead exposure. Hearing impairments and mild intellectual difficulty are also signs and symptoms of low dose lead exposure. High dose exposure, cognitive delays, blindness, paralysis, coma, seizures, and death. You may also see with either low or high dose kidney impairment, impaired calcium function, and anemia. Because the low dose lead poisoning can be so vague and look like other things, it's recommended that children are routinely screened for lead poisoning at 1, 2, and 3 years of age. Their lead levels when screened should be less than 5. If they're above 5, then you suspect lead poisoning. The treatment is chelation therapy with calcium, EDTA. Think of your risk factors of lead poisoning and the education that we provide caregivers. So your lead-based paint, so if they live in older homes or play with older toys or attend daycare or their babysitter lives in an older home, we really want to educate on when they use lead paint. Also think of pica as a huge risk factor of lead poisoning. So if children are eating things that they're not supposed to that might contain lead, then they're at increased risk for lead poisoning. And this is a nice little picture. So it talks about routine screening, washing their toys, possibility of lead being in the water, so only using cold tap water for drinking or cooking, and then test paint, dust in the home if it was built before 1978. So that's kind of the cutoff of when they discovered the harmful effects of that. Complications of infants. So the good news is, good news and bad news. So there's a whole chapter in this. So chapter 42 in your ATI book actually goes over all of these complications of infants. The good news is we've already discussed all of them. The info just reappears here. So think back, this is a good review and you should still read the chapter, but we've already talked about PKU, which is the protein, meningocele and myelomeningocele we talked about with spina bifida. RDS is respiratory distress syndrome, so your signs and symptoms of respiratory distress. Hypothyroidism we talked about. NEC is necrotizing enterocolitis, so we talked about that with your preterm infants. Substance exposed infants, we talked about neonatal withdrawal syndrome. Hyperbilirubinemia, so that's your bilirubin being too high. Don't disregard the term kernicterus, so that's brain damage due to high bilirubin levels. Preterm infants we talked about, and then chromosomal abnormalities we've talked about as well. And even on your other YouTube video that you've watched, it goes a little bit into your characteristics of Down syndrome and the complications that they can experience. So this whole chapter should be a review for you, and I still recommend that you read it. Failure to thrive is discussed on page 280, so it's actually inadequate growth. The inability to obtain or use calories required for growth. So those two things are highlighted because it's the kind of the key indicator whether failure to thrive is organic or non-organic. If we're unsure of whether it's organic or non-organic, you remove the possible non-organic cause and see if the infant gains weight. So for example, non-organic could be neglect, so child neglect from the parents. Organic would be like an actual medical condition, such as cystic fibrosis. So if you're unsure whether it's a child neglect case or an actual medical reason behind it, then if you remove the possible caregiver that's neglecting the child and the child gains weight, then it's most likely that was the cause. But if you remove the non-organic or the parent or the caregiver and the child still does not gain weight, then it's most likely either another bad caregiver or a actual medical cause of the failure to gain weight. So definition wise, it's less than the 5th percentile on a growth chart. The child appears malnourished, they have no fear of strangers, they appear withdrawn and delayed. So it's kind of like they're developmentally, they don't act like a kid normally would their age. So they don't have that stranger, that fear, that separation anxiety type fear.